Operators, Hawaii Emergency Management Agency, Healthcare Association of Hawaii, Hawaii Association of Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. We usually have a brief presentation and then open it up for questions and discussion up to 3 p.m. And we ask you to use the chat box to submit questions. Anyway, next slide. This is a schedule for upcoming sessions. Today, planning a COVID unit. This coming Wednesday, we have COVID readiness in the assisted living facility. And that's going to be, and we actually have folks from HAH and Susie Schulberg from Arcadia and Dan Hamowitz on the mainland talking about that. And then on Monday, the 18th, helping dementia residents through COVID challenges. And so I think that's, I think everybody's seeing that as an issue right now. And then actually on May the 20th, we're going to have Dan Hamowitz come back again, and he's going to talk a little bit more in depth about assisted living facility challenges. So good lineup in the next coming weeks. Okay, next slide. Just reminding you, we are offering CMEs, and in order to receive CMEs, you must register and complete an evaluation. Okay, and anyway, at this time, we ask you to enter enter your name into the chat box for attendance purposes. And for those of you calling in, if you could just let us know who you are. Let me just look in here, like do a quick screen. And it doesn't look like there's a lot of phone numbers. Okay, so great. Okay, so so today's topic is planning a COVID unit, practical tips. And today we have back again Kathy Owens, Chief Clinical Officer of Avalon Healthcare Management. Thank you so much, Kathy, for helping us out so much.
You're so welcome.
Mm-hmm. Take it away.
Okay. So today we're going to talk about how to prepare for a COVID area. And as you know, the process for a COVID unit is critical as your initial response when you get a COVID positive patient. And we're saying lots of prayers and knocking on lots of wood to make sure that that is not something that you have to experience, but it is important to be prepared. So next slide, please. And I love this quote from Louis Pasteur: change favors the prepared mind. And that's what this is all about, because if you do need to have a COVID unit or area, it will be something that you'll need to put into play very quickly once you get a positive test result. Next slide, please. So preparing now is really the goal. And these are the pieces that we're going to talk some about. The location is really critical, and I'll show you a little more about that. The size of unit or area that you may choose to use. You want to also keep in mind, how could you expand that unit or area if you would need to, if there were more cases? How are you going to staff this particular unit? What's the equipment you're going to need? How does PPE play into a COVID unit or area? And then some special tips on caring for the resident who is in the COVID unit. Next slide, please. So location, this sort of looks a little small here, but location is really important, because some of the principles you're looking for is you want to have this unit or area located out of the general traffic area in the facility. You really want it to be a protected area. You don't want people to have to walk through it at all to get anyplace else, because we're trying to reduce the transmission of the virus. And we're also trying to protect everyone in the facility. So really a great place to locate one of these units is at the end of a hallway. And preferably that end of the hallway has an outside entrance. You also want to look at what is the bathroom situation for your rooms. So frequently what we're finding is facilities are considering, where would I put my COVID unit? You want to think about, are these bathrooms shared? You also want to think about the room that's going to be needed for your staff, for a nurse's station, for a place for staff to change in and out of their uniforms when they first come and when they leave. And you do want to have this as a protected area. So I'm going to introduce to you a concept called zip walls that we've been using very successfully to demarcate the area. But the location of the unit is important, and keeping in mind how you'll probably would start out with hopefully just a handful of residents, maybe one or two, but you want to be thinking, what if we had to expand that? So how could you expand that unit over time if needed? Just keep in mind those principles as you're picking your best spots. Next slide, please. Okay, so this is an example of a facility that actually does have a COVID unit. And the where you see the red on here, this is a facility mapping of the infections. And this is actually, I love this map, and I love what this facility has done because it tells a story as well. As you can tell looking at this map, the where the red boxes are is where their COVID positive residents are. And they, where the rest of the house is reflected in green, they've had negative results. There's also red stars where those COVID positive residents may have resided initially before they were relocated to the COVID unit. So this gives a nice kind of history of what's happened in this facility as we've worked through the process of a COVID, of the COVID infection or outbreak. As you can tell, this unit is at the end of a hallway. So what is beautiful about this unit is there's a separate entry into the unit. And so everyone comes in through that separate entry. All the staff comes into the separate entry. We have two ways that we can deliver items to this facility. We try to use the outside entrance for as many deliveries, laundry exchanges as possible. It just keeps that unit pure and very separated from the rest of the facility. So I think this gives you a really good idea of how to think through this. Now, I have been asked on several occasions, can you use office space if you don't have that, that's located near an outside entrance? Can you use that office space that's not designated as a resident room? And for the most part, you really want to try to use resident rooms that are already certified rooms because they already meet all the criteria for life safety. And they also meet sizing criteria for regulatory purposes. If you decide to use it because your census is such that you're not able to relocate individuals, then you would need to walk through your plans with your state agencies, with life safety, et cetera, to be able to get approval for using something that is not a resident room. But the recommendation is try to make these resident rooms that you take out of commission, that you can relocate those residents to another part in your facility. Next slide, please. So one of the things that we have found extremely helpful is the addition of what we call zip walls. This helps to demarcate your area, and it works extremely well. We have been able to get approval from our fire marshals where we've been using these, and that's what I understand from other organizations as well. They are easily installed and quickly taken down so that you can evacuate if you had to. So that's the really cool news. And the other piece here is how much do these cost? Well, believe it or not, you can get them for like $20 to $50 for a zip wall. I'm going to show you some pictures here in a second. You can buy them from Lowe's, you can buy them from Home Depot, and you can get them on Amazon. So these are very affordable options for most facilities. And like I said, it really sends a super clear message to everyone that this is a special unit. You can post signs and say that only authorized individuals can go beyond a certain area. And a number of units choose not to have anyone go through the zip walls at all. They just have them go through the outside entrance. So next slide, please. This is an example of what a zip wall looks like. Now there's something that we've done here. If you look at this, this is an actual unit. And they have, they've combined a couple of zip walls to be able to span the complete width of a hallway. And so you can get creative with these. You can go diagonal with them. So really you can think outside the box on how you want to create your demarcated area. I really like the concept of having what's called an antechamber. And that concept is that you put up two sets of zip walls. One is your outer, and then one is your inner. And so your staff can actually enter into the antechamber, and they can change clothes there and then go into the unit. So it's a great place to change clothes. If you're not able to arrange a resident room for that purposes, you can use your zip walls and create this antechamber. You can also say, well, the right side of the antechamber is the clean side, the left side is the dirty side. So you can have your clean laundry on one side so people can put on clean PPE, and then they can discard their used PPE on the opposite side. So that's another way to think about the antechamber. But it does give you another extra space to work with for your staff to safely don and doff PPE before they may go into the unit. Next slide, please. So this is another example, and someone's showing it. They were very proud of this when they did it. You can see that the zippers are different parts of the wall, so you can, it took a couple of different zippered areas to pull together, but that creates a really nice antechamber. Next slide, please. This particular facility actually created an additional storage area with the zip wall for their linen. And they put that in another room that they were using for the staff. So they wanted to really protect their linen, and they put up this zip wall. So these are some ideas of how you can use zip walls. They are wonderful. And as you can tell, they're put up with duct tape, and you can just easily pull them down if you need to do any evacuation, if there's any problems. Next slide, please. Another step that is really critical is the transfer of materials into the unit. And one of the solutions to this is the use of a transition table. And it can be placed right outside of your COVID unit, and it becomes your drop-off station. So you can have people come and deliver, say, deliver meals to this table, and then the COVID staff can come out and pick the meals up and take them into the unit. So it really minimizes people needing to go onto the unit to deliver anything. You can do the same. You can double bag your laundry and place that on the transition table. Of course, you have the solutions there to be able to wipe down surfaces after usage, etc. So we try to maintain the best sanitation we can in these circumstances. Next slide, please. So what about the size of this unit or area? Once again, really that at least one room for your COVID team. And that room should have a bathroom. It would be ideal if that room also had a shower, because we are finding that staff do like to, if possible, take a shower before they leave the facility. So they're less likely to take things home. We do like a room, a space where people can privately change clothes, and they can change into their street clothes before they leave the COVID unit. And we're recommending that the facility actually washes the COVID unit staff's uniforms or scrubs so that they're, then they don't have to take things home. They can also leave shoes in a bag and just wear the shoes, leave their shoes that they wear in the COVID unit at the facility, and they won't have to take those home. So there's a lot of advantages to having that specialized area. It is worth it for the morale of the COVID unit staff to make this accommodation for them. So I really want you to think through that as you're thinking through your COVID unit process. Obviously, always consider where to place your access points. And then how would the unit expand? We've already talked about that. Sometimes you don't have to expand the unit. Sometimes you'll find that you get several people that with your prevalence testing that you determine there are more people with positive testing. And so you'll need to expand your unit. So always keep that in mind as you're choosing your space. Next slide, please. Staffing, that's always a big issue, isn't it? It's so critical. And I'm going to offer you some suggestions of what to consider as you're planning your unit. We do recommend that you have a dedicated COVID team. And likely and hopefully you'll be starting out with a low number of residents. You're most likely going to need to start with a primary nursing model. And remember, the primary nursing model involves an RN who gives 100% of the care. Now, of course, that will depend on the needs of your resident. And we haven't had many of these units, but we've always started off on a primary care model, except that the residents who need the COVID unit may require extensive services, such as bariatric residents or residents who are highly dependent for care. So you would need to quickly move to a team nursing model, which would include a CNA to assist the nurse in giving care. But if you can stay small, and you may have a 1-to-1 or 1-to-2, up to 1, we figure 1-to-4 ratio for a primary nursing model. We found it successful to have 12-hour shifts, and a schedule that seems popular is having people work 3 12-hour shifts on and 3 12-hour shifts, 3 days on, 3 days off. So you'll need 4 nurses to cover your unit to be able to rotate that type of schedule. And then, of course, if you expand the unit, you'll need to work with your model, and most likely it will be a nurse and CNA model, and then you will work with your teams to determine what's going to be the best schedule. Nurses tend to like the 12-hour shifts. It's been my experience. CNAs frequently are scheduled for 8-hour shifts on a regular basis. In a lot of our facilities, sometimes on a COVID unit, CNAs choose to work the 12-hour shift. So it really is a process that you're going to need to be thinking about. Now, with your pandemic plan, you're supposed to be having an emergency staffing schedule. And that also applies to thinking ahead on your COVID unit. What you'll want to do is you'll want to think about your staff that could be available to work the COVID unit. Then you want to look at their personal risk factors. It's critical to be able to consider that as you're selecting your staff. And for example, we had someone who wanted to work one of the COVID units, and God love her. It's just always so cool to me to see how dedicated our staff are. And she was willing to work the COVID unit even though she was breastfeeding. And we had to advise her, for as long as she's breastfeeding, we don't know enough about this virus that we feel like it would be a safe practice to have her working the COVID unit. So you want to think of risk factors such as that, the other risk factors, the different comorbid conditions, etc. People's capability of working 12 hours and of even doing a primary care nursing model. So think about that. It's better to get that sorted through now before you have to think about it. Now, the other piece with staffing is how do you attract staff to be able to work the COVID unit? There's a couple things you can do. And salary, of course, is one of them. And you need to work that through from a union perspective in case you do have a union representation in your facility. But in addition to that, you could consider what does that staff, that COVID team room look like? How can you make that inviting and comfortable? Your team, this is a time to think about making sure, do they have a TV they could be watching? Now, I know we don't encourage people to watch TV, but remember, they're going to be living back on this COVID unit. They're going to be taking breaks back on the COVID unit. And you want to make this an appealing and comfortable location for them. One of our facilities was able to put some recliners back in the team room, and that was super popular because people could actually rest for a few minutes and put their feet up while they were still working the COVID unit. So it's some things to think about. How is this environment really employee friendly? Also having a refrigerator for staff's use that's dedicated to the staff. They can bring their own food, etc. That's important to keep in mind as well. And as I mentioned, having a place you have to have a place for them to be able to use the bathroom. Would be nice if you could also have a place for them to use a shower, if at all possible. It's not a deal breaker, but it's something to consider. It needs to be big enough to handle a laundry hamper and trash area as well. So keep all that in mind as you're looking at staffing. Now, what about premium pay? And it really depends. You're going to need to look at your market. I know depending on market, sometimes people go $4 extra an hour for the team, but you'll need to float that to see if that's going to be an adequate attraction for your staff. And you could start there and negotiate upwards to see what might make people feel more interested and feel like that they're getting the pay for working the unit. The other piece with staffing to keep in mind is when the unit, especially when the unit gets bigger, is you are going to need a dedicated housekeeper that just lives back on the unit. Remember, some of the guidance is that we wash down the congregate areas. We do that at least twice a day. And then the high-touch surface areas get wiped down at least every 2 hours. So you can have your nursing staff do some of that, but they're not trained in how to do the cleaning of the rooms, cleaning of the congregate areas. You'd have to work with your union and potentially train them. Otherwise, you do need to have staff dedicated to the unit. Next slide, please. So for PPE, one of the values of having a COVID unit or area is to conserve on PPE. And I think everyone's pretty upfront about that. Conserve on staffing, conserve on PPE, and highly reduce the transmissibility of the virus. So this is an opportunity where you have a group of residents with the same infection. So you can use that extended wear PPE in this type of environment. Where it does get tricky is if you have a co-infection. So if you have someone with COVID and they also have a MRSA wound infection, now you're going to have to go back and reconfigure your PPE to be able to accommodate for the isolation precautions needed for that MRSA infection. What we have gone to, which we are now trialing across all of our facilities, is a worksheet that helps the team huddle at the beginning of the shift look at what does my group of residents need from a PPE perspective today for the next 8 to 12 hours, and how are we going to work with PPE, and how are we going to manage assignment and workflow around the needs of those residents. So it's a little worksheet, and you have all your residents in that assignment, and then you have all your options for what you would do for PPE. And now you create a quick reference sheet for your staff, and they can remember, when do I need to change gowns? Can I keep the same gown? When do I double gown? So it gives you some additional guidance. So having that team huddle before you ever start the shift is very helpful and can be used also on the COVID unit. Of course, we still want to use N95s on the COVID unit if they're at all available. Remember, to to also use face shields, as well as if you aren't able to use N95s on a COVID unit, consider the surgical mask with the face shield, because that does offer you some additional protection. And we do definitely want to use N95s with aerosolizing procedures. That is such a must. And remember, on the COVID unit, you want to assess people for their ability to do their own aerosolizing procedure and complete a self-administration of meds. But if our staff need to go in that room during or after the aerosolizing procedure, they should be doing proper PPE and wearing an N95 mask. Next slide, please. We found that it's really helpful to have electronics available. So think about that in your checklist on how do I get my unit ready. You want to have a computer, especially if you're on electronic health records, you want to have a computer available to you for documenting in your Mars and TARS and notes, etc. Also having tablets available. These residents are isolated. You want to give them the potential to use FaceTime or Skype with families and friends, or use them for games, etc., for personal activities. So really think about tablets for the residents. Also think about tablets for the nursing staff. Remember, they're going to be spending time back in this COVID unit. So you want to give them a couple of amenities to make it appealing for them and a comfortable work environment. We have found, especially when there's not a lot of residents on the COVID unit, that it's helpful to have, for the lack of a room monitor, for the lack of a better word, like a baby monitor, that can be placed in the room and also where the nurses are, so that it's another way to monitor how that resident is doing. You need to explain it to the resident. You need to explain it to the resident representative. Make sure they're good with it. Document that. But it's another way to monitor. Because remember, even in our COVID units, we want the door closed if possible to really reduce the transmissibility of that virus. We want to interact with the residents, but we want to manage it so we can minimize those interactions. And having a room monitor can be extremely helpful. And it's a way to converse with some of our residents that can hear or see through that monitor, mainly hear through that monitor. And it's a great way for them to also feel reassured that someone's keeping an eye on them. So we've had some success with that as well. And then, of course, consider a TV in the room with the resident. Now, what kind of room should the resident be in? Ideally, the CDC says the room should be private. However, we're allowed to cohort with like infection, and many of our facilities don't have private rooms. So that's something you'd want to note in your QAPI process, that you're choosing this area in your facility with semi-private rooms. And that can be extremely, that just helps lay the foundation of why you're placing residents where you're placing them. Next slide, please. So how to communicate. This has become so important. It was always important because this is a scary time for residents. I have to share a story. We had one resident that was like a chain smoker, and then as soon as we had informed him that he needed to relocate to a COVID unit and why, he actually was like, okay, I won't go smoke. He actually stopped smoking cold turkey for this. It was very impressive. I felt so bad for him, but it was the right thing to do. But communicating with them is so critical. They don't always know what's happening. They don't understand. We're still learning about the virus. They've been watching TV shows, and a lot of the news is there's a lot of accuracies and there's a lot of inaccuracies, a lot of well-intended reports, but some of them we have to help people sort through. This is a scary time for our residents, for their families, and we need to be able to communicate with them regularly. it's important to constantly be keeping them updated on what's happening with your COVID unit. Remember, with the new regulations that just came out, we are supposed, I think it's F884, we are supposed to be communicating when we have a new positive or suspected case for a resident or for an employee. And we also need to report if within a 72-hour period, we have a combination of resident employees that equal 3 or more of respiratory symptoms, we need to be sharing that in our communication with our residents' families and their representatives. So that is really important to keep that up. And hopefully you already have some of that process in place. I know if any of you have been on some of our prior discussions, we talked about that. You want to have signage for the unit. That helps everybody understand, because people will still walk through those zip walls if you don't tell them that it's not okay to do that. We already talked about room monitors for small units, and then having social media available for your residents. These are all really important. Next slide, please. And then the equipment in the room. This is important to do some planning ahead. Of course, you want to be careful because everything costs, right? And we don't want to burden the facility with a lot of extra costs that may be unnecessary. But you want to source how can you get your equipment quickly if needed. We have found some of the equipment that's really helpful to have are thermometers, believe it or not. We're using these electronic thermometers constantly, and they're not necessarily meant for this level of usage, so we've had to go to backup thermometers. So having thermometers is important. Having beep blood pressure cuffs. Now you can get disposable ones, which are awesome, and you can still clean those between usage. We're finding it's hard to get disposable blood pressure cuffs. So it would be a good time to think about how would we source a unit with adequate blood pressure cuffs. It would be best if every resident had their own set of vital sign equipment. That is your best infection control. So sort of start there and then work through the process and what works best for your facility. Likewise, having stethoscopes available, 1 per resident, would be ideal. The other is having enough pulse oximeters. And if you're currently doing your monitoring of your residents, you've probably seen an increase in the use of pulse oximetry because this is such a respiratory-based disease in large part. So you would want to have extra pulse oximeters available. You can go out and buy them at the drugstores, but I tell you, if you get a surge, even in Hawaii, it may be hard to find them at your local drugstores. So go ahead and start working through Central Supply and finding out where you're going to get these items. And then we do recommend a gate belt per resident. That's the best way. And we still need to use our gate belts. It's really critical. And you're probably not going to have as much therapy happening back on your COVID unit. You're going to have more restorative happening, and we really need gate belts. Now you can get cloth gate belts that you can rewash. You can also get plastic gate belts that you can wipe down. The plastic gate belts sometimes a little more difficult to maneuver, and you want to make sure that you use them properly so they don't cause skin tears. So those are just some tips around the gate belts. The other thing that people will tell you is make sure you have some backup oxygen concentrators. Folks can decline quickly with this disease process. And the other piece is if you can get a hold of high liter flow concentrators, try to get the higher liter flow concentrators. 1 or 2 of those available to you so you can use them quickly. You can also do a white connector to connect the regular oxygen concentrators to create a high liter flow situation. Next slide, please. Dining is also important. What we have found worked really nicely is disposable dinnerware. And you can get those clamshells, like the clamshell holders, like you get from restaurants. You can get disposable trays. You can get the disposable silverware or dinnerware. All of that is recommended. and then you can just toss it in the resident room. But now you have to make sure you have a trash bin that will accommodate that much disposable dinnerware. So that's something else to think about for your COVID unit. Dietary would deliver the food. That's where that transition table comes in, and it works really nicely. The COVID team would be the folks that are actually serving the food. So keep it in mind, we want dedicated staff there. We want minimum interaction from any place else in the facility. And then having refrigerator for COVID teams food usage, also having a refrigerator available to store residents' food that they may have. Next slide, please. So special care needs of the resident with COVID. Once again, we know already it's contact droplet precautions. That is a given. N95s, if possible, for that COVID team, if available. It's still not easy to get. They're true N95s. And then once you get them, they need to be fit tested. And we are seeing surveyors ask more about fit testing. It is difficult to get that done, but you at least need to demonstrate that you've tried, and you want to put that in your QAPI meeting minutes, that you have attempted to do fit testing for your N95s. We have found it helpful to do vital signs at least every 4 hours. But with some folks that are starting to decline, you may need to make that every 2 hours or every hour, or maybe even every 30 minutes. Determine early, as we've talked about before, what are the advanced directives of these residents. If your residents are insisting on being full code, you want to talk with them about what this means for COVID, because you can have a decline very quickly. Within hours, you can have a serious desaturation that occurs. And we just had a case where someone was actually intubated in the parking lot on the way to the ambulance from the facility. The decline can be that rapid. It's really important. And you need to be prepared to have the discussion on advanced directives. You need to be prepared to do the frequent vital sign monitoring as needed. And you know, I realized I forgot something on my communication slide. One of the things that we do furnish our nurses with are walkie-talkies with units outside of the COVID unit, so that if they run into an emergent situation, they can get on their walkie-talkie and someone can come in and help them. Of course, you need to educate your staff outside of the unit what they need to do before they enter a COVID unit, if someone is a backup, clinical backup for the COVID unit. Of course, you want to do alert charting. That goes without saying. And frequently, these individuals, because their situation, can skill in place. Now that we have the waiver on the 3-day hospital stay, you can do the skilling in place. And so now you should be doing regular skilled nursing documentation. For ADL care, we're finding that it's helpful to have a standalone restorative program on the COVID unit, so that your nurse is your restorative nurse, and together the nurse and the aide actually provide the restorative interventions. We're also finding, and we really feel, that it's better to do bed baths on the COVID unit. Now, we don't want to take people off the unit at all to get a shower or bath. Everything is self-contained on that unit. There is concern that with the pressure coming out of the shower head or faucet, that could aerosolize droplets. So we're actually avoiding showers for now until we get different kind of data, and we are pursuing bed baths. So you want to have bed bath material available for your residents back on the COVID unit. Next slide, please. Care planning is always important, and this goes without saying. There's disease-specific care planning for COVID-19. If you all would like, I can send you some samples. You want to address psychosocial issues on the care plan. That is also critical. And you want to be thinking about a personalized activity program for these residents, because they are in self-isolation. It's been hard out on the units. Now it's scary because they're in a COVID unit. Next slide, please. And then, of course, you want to make sure your staff is well educated on COVID-19, proper use of PPE, all the basics of infection control. That all goes without saying. but that's part of the orientation of your staff working the COVID unit. Next slide, please. And one of the areas that has cropped up is important to consider is that of laundry. Now, we all know that you can do standard precautions with the laundry. So what we normally do with laundry, we can do with the COVID patient's laundry, as well as the scrubs from the staff working with that resident. But we just want to make sure that we've got good, strong processes on how we transport linen to and from the COVID unit. So I would recommend that you walk through all these processes that we've been talking about before you ever open up your COVID unit. So you, for example, walk through, this is taking out, doffing my PPE, putting it in the laundry hamper. This is how I collect that laundry hamper so that there's not going to be a chance of contaminating the person picking up the laundry. And then you transfer that outside of the COVID unit to the laundry. Someone from the laundry picks it up and takes it to the laundry, walks through the process of standard precautions for caring for the laundry of the COVID unit. And that would include making sure in the laundry that we're using the right sanitation. If we're using chemicals, if we're using heat as part of our sanitation, we want to make sure as they load the laundry into the washing machine that someone actually sanitizes the rim of the laundry where those clothes may have passed or touched on their way into the actual machine, so that when you finish the laundry cycle and reopen that door, that it will be sanitized fully and you can remove the clean laundry without contaminating it. I hope that makes sense. So you really want to look at the infection control process from start to finish with the laundry. Just like I mentioned with the dishes and the dinnerware and the transport of meals, you want to walk through that process as well. It's really critical. As we've mentioned before as well, with areas like medications, you want to have a medication cart, treatment cart. They may be combined because it's a small unit. So you want this to be a self-contained unit, even with a pill crusher that's available just for that unit. So it's self-contained. Next slide, please. So the last portion, I think, of that really deserves some focus is giving the rendering of palliative care on these units. COVID-19 can have its own particular challenges. As I mentioned, you can have a sudden decline in respiratory system. That means you can desat, and within hours, someone can be in significant respiratory distress. It is a very, very difficult experience for the resident. It is very, very difficult for the staff to witness. So you really want to educate the team on the process. You want to make sure you've got high liter flow oxygen concentrators. You want to make sure you have planned ahead and you have available morphine, Ativan, and atropine, that they are available and ready to go if needed. Because sometimes you have under 6 hours from the onset of respiratory distress to when people are in significant distress. And you really need that morphine and Ativan to be able to help them manage the discomfort. Visitor management is another key component, obviously, for the COVID unit in general, just like it is for the whole facility. So you can still do what I call the window experience and have people look out the window and visit through the windows. Even family members can visit individuals on the COVID unit through the window. But when it comes to end of life, we all know the end of life can be considered an essential visitation situation. Now, it still is important to educate the visitor that they are entering into a very high-risk scenario. And we still discourage them from visiting their loved one because they are at high risk of contracting the disease from their loved one. It is so hard not to touch people as they are going through this dying process. That's one of our major ways of comforting each other is through human touch. And this is such a tough disease. I mean, it is a cruel, sneaky disease. And this is when I say it's the cruelest, is when people experience the end of life in a COVID situation. But if family or friends that are approved visitors insist on still visiting, knowing the risk, it's important that they are screened as visitors. You do not want them walking through your facility, coming in with symptoms of a respiratory illness. They have to go through screening. They need to don the right type of PPE. They need to know how to do hand hygiene. You should be observing them do that. You do not have them do it on their own. You should have someone watching them don and someone watching them doff and coaching them as they do that, because that is a dangerous situation for them as well. If they don't doff properly, they could be contaminating themselves. So it's critical that we are scheduling the visitation so that we have time and availability to educate the visitor, to observe donning and doffing. That is absolutely critical. But we can do some really special activities through the window. I know it feels so impersonal. I really understand that, but I want to share a couple of episodes of where the staff actually made something very special happen, even in this scenario. One was a scenario of a woman who was South Korean, and the family were not able to be right at bedside when she went through her transition and passed. But what the staff were able to do is they brought in the traditional Korean dress, and they were able to dress the body post-mortem. And then the family were able to come and see and do their particular personal worship during that important time. Another example is with a Buddhist family with a patient, and they were able to set that patient up, the family up and the patient, and they were able to do their prayers, set their altar up outside, and the resident and the family were able to engage in their ceremonials that helped them be able to come to closure through this end-of-life transition. And both of those are such touching moments and such gifts that we can give to our residents. So while this is one of the hardest things I have ever witnessed in my entire career, it is still something that, excuse me, because I think this is such a personal time for people, but it's still something we can think creatively and outside the box and provide a very special transition time and experience for the resident and for the family. Next slide, please. So with that, I'll go on and open up for questions. And I see we have 31 in the chat. I'm not sure if they're signing up. Let's see, I think these are people that were signing up to join
They were just doing their attendance things, but
okay.
Yeah, but thank you so much for your sharing your wisdom and your experience with us. I think this is really helpful for us, just as we are just getting started with thinking about how we set up COVID units and how we plan for surge. Knock on wood, should that happen here, we don't want to be caught flat-footed.
And Dr. Wen, I realized too, what I can send a couple of checklists over that you walk through, because what we do when we get into this space of suspected case, we immediately go through a checklist, and then we keep doing that checklist until we don't need to do it anymore, and we do it absolutely daily. And that way we don't miss things, and we pick things up quickly and modify to the situation. And that has proven to be very helpful.
Great, thank you.
You're welcome.
Yeah, so I would like to open this up to people on the call. I know there are folks who have small units, trying to figure out how do we even do this. You know, we don't really have the volume, or, you know, how do we do this on, you know, what do we do with our elevators, the people on the other floors? I mean, there's all sorts of questions I'm sure you have. So please, you have a few minutes to get her experience and wisdom.
Sometimes the time when you start having questions is when you have to use this information. So,
okay, so I'm just going to call on Nicole. Sorry, Nicole. Did you ever get yours up and running?
Yeah, so we are using our swing unit now for our new admission, like a step down into long-term care unit for new admissions.
mm-hmm.
We never had a positive case, so we never actually had a true COVID unit. But that's our plan. That's where they would be, and we have a dedicated staff, and we actually we have a plan to put up a zip wall to separate that small unit into a positive side, and not in our, you know, persons under investigation or persons in isolation side, if we had to.
Good. That sounds like a good plan.
That's good.
Holly McCood did have a positive, though, if they're on the line.
Yeah. Hi, Nicole. I'm here.
Yeah, tell us what you did with your COVID unit.
Well, we had a separate, we were able to move the positive and the other ones that were, you know, had been exposed into a whole separate unit. So we opened up a whole separate unit for them. And actually, there's still one person that's in that unit. And but we've been able to isolate everybody in that unit. And then we have a separate unit that's for the new admissions.
Good, yes. And that's the ideal, isn't it? To have a location where you have your new admissions, where you can put them under contact droplet precautions for 14 days and monitor them to see if they develop any symptoms. And some people, as we're getting into the recovered mode, looking at a similar recovery unit. So, but it's difficult to staff all these different types of small units. So that is something you would have to factor in what your capabilities are as a facility.
Can I ask you about the recovery? Well, what we're dealing with now is R1 positive. He became symptomatic, not horribly, but he became asymptomatic. And then we tested him at day 13 with the plan of doing 2 tests 24 hours apart. Day 13 came back negative. Day 14 came back positive. Mm-hmm. So we tested him on day 20, it was negative. Day 21, he's positive. Mm-hmm. So and meanwhile, he still is in isolation, and, you know, he's actually kind of regressing physically and emotionally. Do you have any thoughts or suggestions on that? What to do next?
It's a great question. You know, we're running into that as well. That's we're still learning about the virus. We've had a couple of individuals that have done exactly that pattern, and we just maintain them on isolation, because just sort of thinking we don't want to expose anyone unnecessarily. So it's right now we're still using what we call the test method, and we're going for 2 negatives 24 hours apart.
Okay.
Then you always want to think about, of course, some of the discussion that's out there is the nasal swab picking up the only fragments of the virus, because it is very sensitive, as we understand it, to those fragments. So you may not be shedding virus, but we don't know. We don't have the capability right now to be able to measure that. At times we've used a little bit of antibody testing just to see in those individuals, are they mounting an antibody response? But as of yet, we don't have good evidence-based guidance on how to even use the antibody testing to make a determination around recovery. So the best that we've landed on is the 2 negative tests at least 24 hours apart to be able to state recovery. And then we put people in a 14-day isolation period. And in our, we've been fortunate in where we've had these COVID units, that they are now opening up testing. And I don't know if you're aware of this or not, but nursing homes, long-term care facilities rose into a priority level 1 for testing just recently. And we were priority level 2. So now there seems to be some more loosening up of availability of testing. And in several of our jurisdictions, we're able to get just automatically some periodic prevalence testing. Maybe not for the whole population, but we can select who those individuals are, so we can increase the frequency of testing to help get those 2 negatives in a row, hopefully.
Okay, so that was one cool thing we were talking about, was maybe doing, instead of waiting another 7 days to do 72 hours, or just try to, because we haven't been having a hard time getting the testing. So
that's good.
I think we can increase the frequency. And
you could increase the frequency. We've got, I'll be honest, we've got some people who've been tested like 7 times.
Okay.
Got those 2 negatives together.
Okay.
The best that we have right now from an evidence base as we learn more about the virus.
Okay, thank you.
That's a great question. Any other questions?
Don't be shy.
Mm-hmm. Dr. Bennett, if people do develop questions over time, because this is when a lot of times the rubber meets the road in these scenarios. So, and there's really always can feel free to reach out and network around that. I found that to be extremely helpful, even for us, is to hear what other people are doing. It can be very helpful.
Mm-hmm. Yeah, because I was just kind of wondering about your thoughts about that cross-training piece, like with restorative care,
Mm-hmm.
and, planning ahead for that, and things like, feeding, having other staff trained to be able to feed, in the event of shortage and things like that.
Right. You need to check your state guidelines to
Mm-hmm.
make sure that you're allowed, and who can be allowed to assist to dine. From a restorative standpoint, we've created a standalone manual, and then we just are educating our nurses and the CNAs on the unit to be able to execute on that restorative and treat it as a separate program from have the routine review of the progress, have an initial care plan, a discharge progress note, we've got it all lined out. So it's pretty transferable and very self-explanatory. And then you can use, we're actually avoiding rehab on COVID units unless we're able to really get the amount of the staff that we need, because we don't want our staff out on the floor, the regular floor, to go into the COVID unit. So you can do some education electronically with the staff on managing the care needs for different restorative clients. It's not ideal, absolutely. But, unfortunately, not a lot of COVID-19 is ideal. We sort of have to accommodate our situation. That's what we've done.
All right. Oh, it's just about 3 o'clock. So let me just, any last minute questions, please type them in. Anyway, just want to remind you, let's see, if any of you are just on phone call, please unmute yourself and tell us who you are. That would be good, just so we know. And we can give you credit. And also, in order to get your CME, please go to the web page and complete the online evaluation. And any comments that you want to give us to help us plan future programs. And also let you know that this coming Wednesday on May 13th, our next session is Readiness in the Assisted Living Facility. And so that should be very, very informative and interesting and exciting. Because I think our assisted living facilities are doing a great job, but we can always continue to strive for even better. Okay, so anybody last minute? Okay, thank you so much, Kathy. We always appreciate your sharing.
You're welcome, and keep up the great work in Hawaii. You guys are doing a great job.
Thank you. All
Keep
right.
the opportunity.
Okay, see you again. Bye.
Bye-bye.